Hey, everybody. Thank you for joining in this um, conference this evening. I am going to um, share my screen so that you can see the slideshow. Let's see. So there we go. So I am going to talk tonight about COVID-19, about what we know about it, the latest treatments, and how we're going to get ourselves out of this mess. So when it comes to this virus, we know that it is a coronavirus. And that simply means that it's a little piece of RNA that is surrounded by an envelope. And so it's just this tiny little piece of genetic code that has a little coating around it. It gets into the body through the ACE2 receptor. Now, early on, there was some discussion about whether or not the ACE inhibitors for people that take things like lisinopril or enalapril, those types of medications for your blood pressure, if it would somehow provide you with some benefit. But that doesn't appear to be the case. But anyway, it does enter through the ACE2 receptor. The virus is similar to SARS, also similar to MERS. In fact, this virus is called SARS-CoV-2 or SARS-CoV-2 because it's very similar to the SARS virus, the first one that came out, I don't know, 5 or 6 years ago, whenever that was. It also is similar to one of the viruses that can cause the common cold. So it's not a rhinovirus, it is a coronavirus, but it can cause, there is a coronavirus that can cause the common cold. So transmission is person to person. And here's what I mean by that. So we all know that there are sometimes you can catch something from an insect, right? If you get a mosquito bite, for instance, you can catch malaria. Or if you get a tick bite, you might get a tick-borne illness. So those are tick vector to human infection. And for this particular virus, though, it's person to person. So you don't catch it from bugs or insects. You don't catch it from animals, or at least we don't think you do. It's primarily person to person. Now it spreads through respiratory droplets. And what a respiratory droplet is a piece of the virus surrounded by a little bubble of moisture. And so every time I speak, every time I breathe out, I am secreting moisture. And so if you have a lot of the virus in your body, you're also breathing out that moisture has viral particles in it. And so whenever you cough or you sneeze or you talk loudly or you sing, you're really pushing out a lot of moisture, and it's going a long distance, and that virus is spreading. Now, that's one way that we see it. It's also, we see it airborne. Now you'll notice I say possibly airborne. And what I mean by that is that we do know that the virus can be airborne. So the difference between respiratory droplets and airborne is that the droplets are a little piece of virus that are a copy of the virus surrounded by moisture that then slowly drops to the ground. Airborne is just the virus itself. It's not covered by moisture. It's just the virus itself being expelled, and it just kind of floats in the air. It's either lighter than air or about the same weight. And so it just kind of floats around. And so that's the difference between the respiratory droplets and airborne. But we don't see a lot of airborne transmission. And I'll go into why that is in a little bit, but it's primarily through these respiratory droplets. Now, there's little to no evidence that this gets spread by what are called fomites. And so a fomite is any inanimate object that can get virus on it. So like, let's say a doorknob, that somebody who has the illness, they cough into their hand and then they touch a doorknob. The virus doesn't seem to spread that way very easily. Now, there are some viruses that do. For instance, a lot of the GI viruses that we know about can really spread easily through fomites. So you touch something that somebody else has touched and then you get it. But respiratory viruses don't tend to spread that well, and this is not this one is the same way. So no need to worry too much about fomites. Now, close range contact increases the risk. So those respiratory droplets that I was talking about, because they're heavier than air and you spew them out, then they tend to go out and then they slowly drop down to the ground. But they'll do that within a range of about 6 feet. Very seldom do they get farther than that because of the weight. They just simply drop to the ground. Now, crowded spaces with less than adequate ventilation will increase your risk for the airborne. Well, both of them actually, but this is where airborne transmission comes in. So if you're in a bar or a restaurant, there are a lot of people standing around, everybody's talking, they're talking loudly, maybe they're yelling it across the room or something like that, and there's a lot of people in a tight space, not real good ventilation, then that airborne virus is going to start to dissipate into the air, and but the more of it that gets generated, the more dense that those viral particles become in the air, and so then you end up breathing that in, and so that's where airborne transmission becomes an issue. Now, the greater the viral load in a person who's infected, then the greater the risk is to others, and that's kind of intuitive, I think. So if somebody is, let's say that they're really sick and you got to put them on a ventilator, and so you're standing over them and you're putting in the breathing tube so that you can hook them up to the ventilator. They've got a really high viral load, and so that higher that viral load is, then the greater that the more number of virus particles they're going to spew out when they cough or they speak or whatever. Now that's a problem since their viral load is greatest before they're symptomatic. So when you talk about viral shedding, which is when you're able to spread the virus. So when you think about viral shedding, a person is more likely to be contagious early in the illness. And so, in fact, they can infect other people 2 to 3 days before their symptoms even start. And so that's kind of scary when you think about it. You got people that don't even know they're sick and they're running around spreading this virus 2 to 3 days before they get sick. And their peak infectiousness is their first day of symptoms. So they're in rising in infectiousness, and then finally they get symptoms, and that's when they start to go downward as far as infectiousness goes. Now, typically, once a person begins to shed virus, they're able to infect people 7 to 10 days after the symptoms onset. And so that's why the CDC and the Department of Health are all saying, you need to stay at home for 10 days after your symptoms start. Now, a person's COVID test can remain positive for several weeks or even months after infection. So this has been kind of a problem. It was a problem for us earlier in the pandemic, not quite so much now, but when it first started showing up here in some of the food processing plants, somebody would test positive and then they would do their quarantine and their symptoms would be gone, but their workplace wouldn't let them come back until they tested negative. Well, some people, they test negative right away. Other people can go on for weeks and still have a positive test. And so what we found out is that this increases with age. So the older you are, the more likely you are to test positive for a longer period of time. And it seems like the more severe your illness is, the longer you're going to test positive. But you're more likely than not to not be infectious during that period. So you're most likely not infectious. So let's say that it's been 2 weeks, your symptoms have been gone, and you're still testing positive. You are probably not infectious. And so there really isn't a reason to be tested again unless your symptoms return after full recovery. So what I mean by that is if you get sick, you test positive, and you do your quarantine, your symptoms go away, there's no need to get tested until or if you get sick again, let's say 2 months down the road, you get sick again, yeah, you need to get tested again because you may have it again. And we'll talk about that here in a little bit. Now, another interesting aspect of this disease is that many infected people don't infect other people, which is kind of surprising because you know, we kind of think about this as being a very infectious disease, and it is, but as it turns out that there are these so-called super spreaders. So these are people that they may infect hundreds of people, and other people only infect one person or two people. So we don't really know why that is, but we saw a case here in Arkansas very early on in the pandemic. There was a choir, church choir, and they met for 3 hours on, I think it was a Saturday afternoon, and there were, I don't know, 30 or 40 people there, maybe 50, and one person had the virus, and they were asymptomatic, but they became symptomatic very quickly after this choir event, and ended up infecting like 30 or 40 people. So that one person spread it to this big group of people. And so you had now in this small town, you had all these people who were sick, but they didn't spread it to very many other people. So the first person was the one who spread it to so many people, but then those people did not spread it to more than one or two others. So we don't really know why somebody is a super spreader. It may have to do with the setting. So obviously they were in a choir and they were all singing and they were in close proximity to one another. And so maybe that's what causes a person to be a super spreader. Maybe it's more the situation as it is than it is the person. So, but we don't really know that for sure yet. All right, infection rates tend to be highest in households. And that kind of makes sense if you're living with someone, your spouse, your partner, your children, your parents, whatever the case may be, and they get infected and they're at house in the home with you. Obviously, you're having close contact. You're not wearing masks, and so your risk of infection is much higher. Healthcare facilities in which they're not using proper PPE or personal protective equipment. Again, here in Arkansas, very early in the pandemic, in fact, before we really had, I think we had maybe one case, maybe two in the entire state. There was a hospital that a person came into the ER and they had been traveling, and the ER just wasn't even thinking about this pandemic yet. And, you know, we live in a kind of a conservative state. And so there was quite a bit of this, oh, that's just a bunch of liberal nonsense. And I don't know if that's what those people were thinking, but there was a lot of that going on. And then, so when this person went into the ER personnel were not wearing personal protective equipment. Turns out that this person was quite sick with COVID, ended up infecting 30 or 40 or 50, whatever it was, of the hospital staff before they realized, oh my gosh, we need to protect ourselves. And so we've seen that in some situations. And then obviously anywhere where people live, work, or relax in close quarters, you're going to see the potential for spreading this disease. So prisons, cruise ships, of course, we all remember the cruise ship, that first cruise ship that became so famous. Food processing facilities, I mentioned earlier that we process a lot of food here. The chicken factories, these people they just literally shoulder to shoulder, and big long lines of people, and so they're much more likely to spread the disease if it breaks out in that setting. College dorms, bars, restaurants, any place like that where there are a lot of people gathered together in close quarters. So let's talk a little bit about symptoms. The four most common symptoms I've listed there: cough, fever, fatigue, shortness of breath. Those are the ones that you're going to see most often. Then sometimes we'll see body aches, headaches, sore throat, diarrhea, nausea, vomiting, loss of taste or smell. So when somebody comes in we have a drive-through screening for COVID, and they come in, they're complaining of nausea and vomiting, diarrhea, our first thought is not COVID. But if they also have shortness of breath or they have cough, yeah, we're thinking COVID before we think about GI, some sort of a GI issue. So body ache, sore throat, diarrhea, loss of taste, those are all kind of the secondary batch of symptoms, whereas cough, fever, fatigue, shortness of breath are your primary symptoms. And you can have any combination or just even one of those symptoms. Sneezing and congestion are rare with COVID. Typically, if you have sneezing and congestion, you probably have allergies or you've got a cold, a head cold. Now, if you have sneezing and congestion, but you also have fever and fatigue or shortness of breath, we're going to think COVID because that's what's circulating right now in our community. Now, there are 4 possible or potential stages of this disease. Everybody goes through that first stage. If you have COVID, you got to get exposed to it. So obviously, so you go through exposure and then you begin to incubate. The virus begins to replicate in your body. Now that could actually last up to 14 days. So you can get exposed and then take up to 14 days before you start to show symptoms. And in fact, I had a patient recently that was exposed and then 12 days later tested positive and started developing symptoms. So we do see it. That's not the most common. Most common, people start 5 days after exposure. Now, before kind of insert in the middle of that, the vast majority of people have no symptoms. And so something like 70%, maybe as many as 80% of the people that get COVID don't develop symptoms. And so, or if they do, they just have maybe mild fatigue, or maybe have 1 day of low grade fever, or something like that. So it's not at all uncommon for people not to have symptoms. But for those that do get symptoms, typically they start 5 days after exposure. And interestingly, and I mentioned this kind of a little bit of this earlier, that their highest viral load is usually that first day of symptoms. So it's kind of interesting that it works out that way. Now, most people that get this, that's the end of it. They go through their 5 to 7 to 10 days, whatever, of symptoms, and then they're done. They're over this. But for those people who wind up getting sick enough to go to the hospital, a small percentage of those will get what's called a cytokine storm. So this is kind of an immune system overdrive. They get cytokines are part of they're pro-inflammatory. They lead to inflammation, and so you get this huge surge of inflammatory cells that just kind of hit the whole body all at once, and cause multi-system organ failure. So heart, lungs, kidneys all start to shut down. And so this can happen 6 to 10 days after infection. And so in some of these people, we've seen where they've got sick, they go to the hospital, they get admitted, and then they actually get better and go home, but they're back 24 hours later, severely ill, and they have to be intubated and be given high dose steroids. And then often they don't survive. So obviously most people who get this disease don't have that. And then the post-infection complications, this is something that we're seeing with people that they get exposed, they get sick, they develop symptoms, and then they have these post-infection complications. So in other words, they got over the infection, and they're probably even testing negative, but they still have lingering symptoms. So maybe they have this just chronic fatigue that won't go away, or they still have body aches or headache, or their loss of taste or sense of smell, and it persists in some people for months. I was reading about a doctor who developed COVID, and then she got better, she got over it, but now still has this severe fatigue where it's a struggle just to get out of bed every day. And so we're seeing that. It's kind of like, we see that with other viral infections sometimes. You've heard of chronic Lyme, maybe some of you've heard of that, chronic Lyme disease, or chronic fatigue syndrome, or fibromyalgia. Those are all thought to be, at least in some situations, related to a previous viral infection. And so it just goes on and on and on. We don't know yet how long that's going to last with COVID or how many people will get it, but it looks like about 10% at this point. Now, reinfection, it really seems, the risk of that seems pretty low. There have been some documented cases, but not that many. Of course, there's a lot of anecdotal cases where people have been reinfected, but actually documented with PCR, very few. Most of them were 3 to 5 months later. So you have somebody that got infected, they tested positive, they had symptoms, and they got better. And then 3 months, 6 months, whatever later, they get sick again, they get tested again, and they're shown to have it. Now, in those cases, they all had slightly different variants of the virus. So they weren't just still testing positive. They actually had just a slight variation of the virus. And so their body's immune system was not able to recognize that it was the same infection. And that has some pretty concerning implications for vaccine effectiveness and this idea of herd immunity. And just to address herd immunity right now, if you think about what herd immunity means, it means that if enough people get the illness, then there's so many people had it that the disease can't spread anymore. There's just not any new host for it to infect. Problem with that, with this situation, is that if immunity is wearing off and people can get sick again, then obviously herd immunity doesn't mean a thing. All right, so let's talk a little bit about treatment. If you're not hospitalized, the treatment is supportive. In other words, Tylenol to help with your aches and pains and fever, and then just relaxing and resting, sleeping, that sort of thing, staying home and quarantining so you're not infecting other people. But it's supportive care, just trying to make you feel comfortable. If you get sick enough to go in the hospital, well, that treatment has actually improved quite a bit since that first case that developed in Wuhan. Kind of the standard of care currently is that we treat you for the flu until we're certain it's not the flu. The flu is circulating in the community, and there have been at least one case I know of where somebody had both COVID and flu. So when we put somebody in the hospital, we make sure we go ahead and start treating them for the flu, because if it is, maybe we can knock that out and get them home. And then if we find out it's not the flu, then we stop that treatment. We also try to prevent blood clots. When you have a lot of cytokines circulating in your system, you're more apt to get a blood clot. And obviously that can lead to stroke. It can lead to a pulmonary embolism, a variety of other things. So we want to make sure you don't get blood clots. So we'll treat that. Tylenol for fever, of course. And then those people that get severely ill and have to be on a ventilator, they've got to have oxygen to help them stay alive. We give them dexamethasone, which is a steroid. And so we just slam them with the steroids to try to mute and tamp down that immune response so they don't get that cytokine storm. Remdesivir, therefore, I don't know, 4 or 5 months ago, it seemed like that was going to be the great savior for us. Now we're kind of using it on a very narrow patient population of those people that are sick enough to require oxygen, but not so sick that they have to be on a ventilator. So once they get to the point where they're on a ventilator, remdesivir doesn't seem to help much at all. People that aren't very sick, also, it doesn't seem to make much difference. So we're using it mainly on those people that just need oxygen. Convalescent plasma also, maybe it's helping, maybe it's not. We don't really know enough yet. What that is basically convalescent plasma is if I get sick, and I get better, then I've got antibodies to it. And so you can take out my blood and spin it down and take those antibodies and give them to somebody else. And then theoretically, then they'll have antibodies to it. And so they'll be able to get better. But we're just kind of seeing mixed results with that. And it's uncertain if that really helps. Interleukin-6 pathway inhibitors have not really shown much benefit. Hydroxychloroquine also has not shown a benefit, and that was really touted and pushed early on as being a great medication to help make this thing go away, but doesn't really show to be a benefit for when people get sick. appear to be a benefit to help people keep from getting it. So doesn't really seem to be much use to it. Obviously masks are one of the best things we can do to stop the spread of this virus. Now, in our clinic, we wear this kind of a mask. It's a little, we call it a surgical mask, a disposable mask that we use. And if I remember correctly, this is an N65. In other words, it filters out 65% of viral particles. So not as good as an N95, which filters out 95% of viral particles, but it's still, still pretty good. And if everybody's wearing one, then it works great. Because if it filters out 65% of my viral particles, filters out 65% of that person's viral particles, then you've really reduced the number of viral particles that are circulating in the air. Obviously, if we could all wear N95s, that would be great. Because then it's 95% that's being filtered out, but those are still in kind of short supply. Social distancing also helps. I mentioned earlier about the respiratory droplets and how they slowly drop to the ground, and they don't typically travel more than 6 feet. And so keeping your distance of 6 feet, at least, farther is better. Then that helps. Hand hygiene, also really important. Washing your hands every time you, particularly for those of us in the healthcare area, every time we touch a patient, we wash our hands so that there's no chance of us spreading it. But also the risk then of taking it, we all touch our face a lot. And so, if I'm touching a patient who happens to have COVID and then I touch my eye or I touch my mouth, then there's a risk that I'm going to infect myself. And so washing our hands is really important. Avoid small spaces that don't have real good air circulation. So airplanes, really bad idea, in my opinion, to be flying right now. Bars, clubs, gyms, anywhere where people are talking loudly, and so they're spreading a lot of respiratory droplets, and typically people are much closer together. Small rooms with meetings with multiple people, like a meeting. We held this conference online because we didn't want to have a bunch of people in a room where you've got people talking and asking questions and that sort of thing. Vaccines, we know that vaccines work. They're a proven method of disease prevention. And I think about all the different diseases that over the last century that we've been able to almost simply eradicate due to a vaccine. So we know that they work, but whether or not we're going to get one for COVID, there's some challenges here. Now, currently, we know we don't have vaccines available, but there are 48 vaccine candidates that are in human trial stage. So they're actually in human trials. Now, there are several phases of human trials. And so that there's the third and final stage of human trials. There are only 2 vaccines that are in that stage. And the companies that are doing that, Novavax and Inovio Pharma, are both saying they are going to have a vaccine available by the end of this year. Now, time will tell, of course, if they're effective and if they're safe, and they're supposedly establishing their safety in these trials and efficacy as well. But sometimes when the vaccine gets out of the market, we discover there are things about it that just didn't show up in the trials. So we'll see. And even so, if they are able to get out in December, only about 100 million doses. Now, that sounds like a lot, but there are almost 8 billion people on the planet. So 100 million doesn't go very far when you got 8 billion people all wanting a vaccine. Most of the companies that have candidates in the human trial stage, are saying that they think they'll have their vaccines available by the middle or end of next year. Again, it's who knows how well these are going to work, how well they'll last, and then their uncertain production and distribution capabilities. So you think about having to make 8 billion vaccines. That's a lot of production. And then how do you get those vaccines distributed quickly in a way that makes sense? So there's a lot of that still ahead of us. We're going to keep plugging away at it, but it's not there yet. All right, so that's the end of my presentation, and we'll take question and answers at the end of Dr. Loudermilk's talk.